Para comenzar la primera parte de esta jornada, le voy a dar la bienvenida a Douglas Sato. Douglas es neurólogo y superintendente de docencia, investigación y desarrollo del Instituto de Cerebro de Río Grande do Sul y profesor de medicina de la Pontificia Universidad Católica de Río Grande do Sul. En esta oportunidad, Douglas nos va a hablar de la fisiopatología y los test de laboratorio en enfermedades del espectro NMO y enfermedades del espectro asociados a anticuerpos anti-MOG. Va a ser un placer escucharlo. Bienvenido, Douglas.
Hello, everyone, and thank you very much for the invitation to talk with you today from the organizer of Latin America Symposium on NMOSD. I would like to present you with the pathophysiology and lab testing in NMOSD and MOGAD. These are my disclosures, nothing related to this presentation. So if we go with NMOSD at a glance, we will not go through the prevalence as we'll have some lectures on that, but it's important to inform you that aquaporin 4 IgG, so the antibody that's presented in the majority of the patients with NMO, is a diagnostic and also a very important pathogenic antibody. We need to differentiate NMOSD from MS, as MS treatments may worsen NMOSD. And a lot of new treatments have emerged from the better understanding of the disease mechanisms, like eculizumab, inebilizumab, and cetralizumab. So I hope that we can give you some background to understand the new treatments that have been tested for NMO in the last years. So when we review the NMO and we will go through the pathogenicity, basically what we understand a lot is related with the aquaporin 4 positive patients, which produce the antibody in the periphery, goes to the CNS, and binds to the aquaporin 4 that's expressed in the astrocytes and promotes inflammation. So we have a lot of things that are based on the understanding that we have an immune-mediated astrocyte injury in NMOSD. So what we have learned from the pathology, it's this evidence that we have complement in the tissue that has been attacked during the NMO attacks, and then you have a lot of infiltration of inflammatory cells, neutrophils, some eosinophils as well, and we have this the complex of complement that's also present in the NMO lesions together with the aquaporin 4 antibody. We have in the right side a lot of GFAP loss. GFAP is an important fibrillary protein, so it's structural protein for astrocytes. It means that you have a loss of astrocytes in the tissue, and also this is followed by the reduction in the expression of aquaporin 4 in the tissue. Another evidence is that we have an elevation of a CSF of anaphylatoxin, that's a C5a, that's a part of the C5 that's blocked with C5a and C5b, and you have the formation of a membrane attack complex when you deal with the activation after the antibody binding. So this is a very compelling evidence that complement is highly involved in NMO attacks. Another piece of evidence is that we have the antibody binds to the astrocytes, and then what about the astrocytes? So if you see the levels of antibody during the attack in the CSF, you have a very important elevation, and this correlates very beautifully with the astrocyte damage and also with the elevation of interleukin-6. So that's another target that we have in the last years being tested in NMO. So if you look about the cytokines profile, you have IL-6 with a very good correlation with the presence of aquaporin-4 antibody in the CSF, and we have the elevation of other cytokines that may be related to the incremental effect that you see with the inflammatory lesions. Plasmablasts. So plasmablasts are B cells that are very mature and they are capable of producing antibodies. And in NMO, the patients have an elevation of plasmablasts. And what's interesting with the plasmablasts requires interleukin-6 and other cytokines to produce and to survive in the peripheral blood or even in the CNS. So when you block the IL-6, you change from a very high proliferation of these cells to a very low level after this intervention. And that's interesting because if you think that plasmablasts can produce, and the group from Professor Yamamura has demonstrated that you can reduce the number of antibody levels and also to change these kind of cells that can induce other immune response. So it's another very compelling target for NMO. So if we try to understand in summary what happens in NMOSD, the aquaporin-4 IgG and the cells can produce and penetrate in the CNS. Then the aquaporin-4 IgG binds to the aquaporin-4 that's expressed on the astrocytes. This leads to the activation of the classical complement cascade, and that promotes a lot of astrocyte injury. As a response also to the immune activation, you have a very important inflammatory response. And at last, you have another recruitment of other cells like granulocytes and the neuronal death and secondary demyelination. So when we see the patients and try to link this physiopathology and the huge amount of knowledge that has been established in the last years, you see a very severe optic neuritis, you have a longitudinally extensive transverse myelitis, or some brainstem lesions. That probably will remember you about NMO, especially in a patient that's non-Caucasian and can be tested and confirmed as aquaporin-4 IgG positive. Moreover, when in the previous diagnostic criteria, there were some restrictions regarding the brain lesions, and now we know that these brain lesions that has been described in NMO actually are very common and can be present in up to 30 to 40% of the patients. So now, after the 2015 diagnostic criteria, this patient have like a 53 years female that came with a prolonged episode of nausea, vomiting, and some extension to limb paresis. That's very important that if this patient is diagnosed, as it has been the case with aquaporin-4 positivity, this can be now diagnosed as NMO and the patient has been treated properly. It's important that this patient, and that happens a lot in NMO, is the overlapping with other rheumatic diseases like lupus and Sjögren. So it's interesting that patients that have previous diagnosis with hematological disorders can also develop NMO, and actually the patient have more than one autoimmune disease. So what the lab testing can help us to understand the clinical and not also the physiopathology of the disease. So as we improve the assays that, with antibodies in the labs, and now we use live cell-based assays, but there are other methodologies still on the routine labs, we actually saw that we increased the number of seropositive patients. And we still have seronegative patients, but the question is, are they really the same as the patients that have been confirmed as Aquaporin 4 positive cases? That's something that we need to be very careful. And actually, the new diagnosis criteria really became more restricted to limit the diagnosis of seronegative NMOSD. So by the time we hope that the cases like these that have 4 attacks before the confirmation of Aquaporin 4 become more and more uncommon. So we really hope that we can diagnose the patients and treat the patients very early in the first attack. And at that time, we can confirm the diagnosis of neuromyelitis optica. So it has been a while since the discovery of Aquaporin 4 antibodies. It started with a number of patients that have been diagnosed with NMO and also with high-risk syndrome. It means longitudinal extensive transverse myelitis, very severe oculoneuritis, and you have 2 patients that have been diagnosed as MS, but actually they have oculoneuritis or myelitis. So probably they were misdiagnosed at the time that they didn't have any testing to confirm the disease. And 1 year later, that at that time has been named as NMOIgG, the group from Vandelena at Mayo Clinic discovered that actually NMOIgG binded to Aquaporin 4, so the name of the antibody probably is more appropriate to be antigen specific. It means Aquaporin 4 IgG. About also the testing and the Aquaporin 4 IgG titers, depending on the methodology that you use, can change a little bit. And of course, that this may lead to some false negatives. And it's important so to try to use the best assay that you have available. And in our case, we use transfect cells with live transfect cells with the isoform M23. That's the short length that promotes very good sensitivity compared to the commercial ones. And that's important. And the group from France just showed that depending on the assay, you start to see more difference between the positive and negative groups. So it's really mandatory that we need to try to work hard and get the best assays as this increases our positivity to the antibody. The performance of Aquaporin 4 IgG assays, and this is a work from Patty Waters from Oxford, and it shows that you have a lot of difference between labs. It means that the experience of the lab is very important to run the assays, no matter if they use commercial, no matter if they use live CBA or even flow cytometry. So it's important to get the result and interpretation from an experienced laboratory. What about the availability of the testing worldwide? So it's important that the Aquaporin 4 and later the MOG we can test the patients, especially on high income and upper middle income countries, but it's very, very limited in the low income countries, as you can see here in this percentage. So only 15% of the centers had access to Aquaporin 4 in low-income countries. MOG testing is very good on high income countries, but when you go to even to upper middle, like Brazil, you start to have a very few number of centers that can actually test the patients for MOG. Another interesting point is that we have this understanding of the majority of the patients, but this is just to call the attention that even pediatric population can present with NMOSD. So, and that's very hard sometimes to differentiate from MS, as the patients with MS in pediatric age may have longitudinal extensive transverse myelitis and a very active disease. So sometimes it's very hard to differentiate if you don't have the antibody testing. Another you may have more than, as I mentioned before, more than one disease in the same patient. This is a case series of patients that have myasthenia gravis and NMOSD. And that's interesting that the timing that starts one disease is different from the another. And we were not sure, but it seems that in some patients, the thymectomy was important, maybe to promote a kind of shift. So the patients got better from the myasthenia gravis, but actually facilitate the development of acquiring 4 antibodies. Now about MOG. So MOG is a very high controversy entity in the last years. So is that really something that is becoming a new disease? And it seems that the tendency is to say yes, but still a lot of controversy around in the literature. So we have published this already in 2014, but we have reproduced these results in many other groups across the world. And that's interesting that now we know that MOG positive patients seems to be distinct from NMOSD. And what is interesting, like in this case, they have bilateral optic neuritis really going through quite extensive in the nerve, but they usually don't affect the optic chiasma. That's something that we see in patients with NMO. Another thing is the lower spinal cord lesions, like this in these children, and that's something that it's not usual to see in patients with ACORN4 positive NMOSD. So another piece of evidence about the physiopathology now about MOG is that we saw in this patient elevation of protein, myelin-based protein, so MBP in the CSF that without any astrocyte injury. So the GFAP levels were undetectable. So the pediatric patients with a MOG seems to be a very important group. So I really bring this to remember you that we may have very severe optic neuritis and also longitudinal transverse myelitis in kids, and we need to think about MOG as well as NMO in these patients. So the evidence that we have about the myelin damage is quite compelling. So we are quite sure that we have this demyelination, and this is in the same level as the patients with ACORN4 and a little bit higher than the patients with MS during attacks. But the astrocyte damage is basically seen in ACORN4 antibody positive patients. So MOG patients basically don't have astrocyte injury. That's important to separate these patients from the NMOSD. And the cytokine profile, that's interesting that we have elevation of many cytokines like interleukin-6. We have some others that comes together, and that suggests that antibody-mediated diseases have some pathways that may be common, and that seems to be distinct from MS, that we don't have antibody that can mark the disease until this moment. From the clinical, what we can use as a hint to suspect about MOG, we have a lot of pediatric cases. The clinical phenotypes can be usually the octoneuritis, the acupuncture negative, NMOSD, encephalitis that include the cortical encephalitis that has been described in MOGAD, ADEM cases, and myelitis cases. So it's really, patients that are non-MS inflammatory CNS disorders, but sometimes the differential diagnosis may be not so easy as in other situations. About the assays, so as we have a number of improvements with acupuncture that start with tissue, and then now we use cell-based assays. Cell-based assays are the basics for the diagnosis of MOGAD. So we have here in the left the cells that have been transfected in the lab, and we can see the positivity with the antibody binding to the cell membrane. And if you go with flow cytometry, you can see that cells that has been transfected, so they express the green here in this case, and we mark the secondary antibody, anti-human antibody. When you have a negative sample, you don't have elevation. When you see with a positive sample, the cells that are transfected with and expressing the MOG really have a high binding of antibodies against them. And this correlation between the what we see in the microscopy and also in the flow cytometry is very good. And we have recently compared many types of analysis that we can do with the two methods, and sometimes very hard cases can be elucidated using more than one method that can be have some limitations that you can overcome. We are working for a number of years already with a group that is working about MOG. So we hope that some of the guidelines and the diagnostic criteria just come out from an international panel and some consensus that can have about MOG. And the conclusions are the NMOSD. So more and more we had confirmation about the pathology and lab testing for acupuncture IgG positive cases. We still have negative cases, but what about them? So if it's an assay limitation or they are truly negative with other disease mechanisms. The antibody detection by cell-based assay, we can have the commercial or in-house as we do in our center for acupuncture IgG, but it's important to have the experience of the center to analyze the data. The treatments are based on observations that are related to disease mechanisms. So we have at least 3 that came out from the research that has been evolved in NMOSD in the last years. About MOGAD, so MOGAD, I have shown you that we have demyelination with myelin damage associated with cytokine elevation in the CSF, and the MOG assays are getting better and better, and probably we recommend that we try to use as much as possible the live CBA. It can be by flow cytometry or microscopy, but again, it's important to have the experience of the center that is doing the test for you. That's it. Thank you very much for your attention.